everybody. So this is a 55-year-old gentleman who has presented to our units with symptoms of occult GI bleeding that has been ongoing for a while, but he has not really had any anemia at any point in time, and the GI bleeding has actually been mostly of an upper source. We did a gastroscopy on him yesterday that showed that he had an elongated Cameron lesion in the fundus that seems to have bled multiple times that we treated. Afterwards, we carried on with the colonoscopy, where we identified a lesion in the descending colon, but the patient was not prepped properly, and because the lesion looked very suspicious, and we could not ensure that he had a clean colon, despite being able to pass the lesion. So we decided to admit the patient and give him another bout of bowel prep and redo the procedure to ensure the magnitude of the lesion that he has in the descending colon, as well as if he has any other synchronous lesions higher up in the large intestine. Now, the patient has not had symptoms of CRC. He has complained of some abdominal pain here and there. He has complained about pain in his foot, and he does not have history of colorectal cancer. The reason why we decided to abort the procedure yesterday and bring him back despite intubating him all the way to the rectum is because we were not able to actually identify the exact location of the first lesion, which is already shown in the picture right now. And secondly, because we could not ensure that he does not have anything else higher up. So this is one of these cases where it's very important to think about good resource management and what to do. I mean, obviously, we saw this already yesterday, and we identified that it looks like a malignant condition. So we're going to do a run through quickly through the lesion before we proceed. So as you can see, it's an exophytic lesion that is filling up the lumen, and it's quite long. It's a few centimeters long, and it's very frail, friable. It's bleeding easily. You can see that the surface pattern is irregular, specifically in this here and right in the middle of the lesion. And then if we switch the MBI to study the microvascular structure, you can easily see that the blood vessels are amorphous, and there's a total loss of the vascular tree here. So in terms of classification, this is a clear, nice 3 Paris 1S. It has a 2C component right in the middle where it's like depressed, and JNF 3. So this lesion so far has not been causing any obstructive symptoms for the patient. He has been able to pass the stool regularly, and there hasn't been much blood in the stool, as we said in the beginning of the video. So now we passed the lesion, and you see, we admitted the patient, we gave him another bout of bowel prep, and we still see that we still have some of this stool-colored fluid lying around, which may obstruct visibility, but it's much better than yesterday. And in these cases, Sometimes it's possible to do a CT colonography when it's not feasible to actually see the whole colon. But if you can pass the lesion, it is highly recommended to actually try and examine the whole large intestine, see if there are any other synchronous lesions that can be removed or are amendable to endoscopic therapy before sending the patient to the surgeons, or it can be also done afterwards, because this will actually determine the extent of the resection that he will be undergoing. Of course, the patient will have to undergo some radiology for staging of the tumor, but if everything goes well, then this should be laparoscopically reachable lesion. But if he had another lesion that looks suspicious higher up in the colon, then we are in a whole different. We end up in a whole different clinical scenario, where the resecting would be much more extensive, and in terms of patients' morbidity, will definitely be much more significant. Now we're using a PCF H290 scope. Fortunately, we do not have the near focus mode here on this one, but it's a good enough scope to actually identify and investigate the lesion close, especially if we combine it with MBI and the use of water jet. And as we proceed, we try to suction out this fluid. We can suction the fluid in order to proceed. So I think we're right now at the hepatic flexure. Patient has slight discomfort, so he has not received much sedation for this procedure. So we're going to give him some more sedation right now. He's received some Buscopan as well at the beginning to keep the colon from moving too much. And you can see here, like, we're almost reaching the cecum here. Try to take it easy. And you see, like, despite having another bout of bowel prep, the bowel is not really optimally clean, but it's good enough to actually investigate all parts of the colon and to be able to tell whether there is something else that needs to be paid attention to. So right now we are in the cecum, and there's the IC valve. I'm using a distal attachment, which usually helps in navigating the folds, reducing the amount of CO2 that needs to be used. On the other hand, it's quite detrimental when the colon is not clean, because you may get some debris stuck to your lens all the time, and inside the cap. Can be slightly annoying for the endoscopist. But we should never accept inadequate bowel prep, because it may have serious consequences for the patient. So now we're in the terminalium, and we're happy with what we're seeing. Looks healthy, nothing out of the ordinary. We'll take another look in the cecum here. And as we're now start the withdrawal process, it's a good idea to give the patient 10 milligrams more of Buscopan to ensure that that we are not to ensure that we can see every part of the colon properly. Now, I have kept the patient on the left-hand side the whole exam, just for the sake of the patient in this case, really. He's been quite nervous about this procedure because we kind of informed him yesterday that there is some lesion that we'll be looking at. But what's reassuring so far is that I have not seen any synchronous lesions, and the rest of the colon so far looks very healthy to me. And it's important to investigate every part of the colon as we retract the scope, because this patient undergoes resection. The first screening that will be done, or the control that will be done according to guidelines, will be depending on what we're doing, from 1 to 3 years maybe. Most of the time it's about 3 years afterwards. And we miss some lesion that might be dysplastic. This may definitely have severe clinical consequences for the patient. Additionally, if the patient has 2 synchronous lesions and he's not really old, we always need to think about hereditary conditions that may contribute to these findings, such as Lynch syndrome, among others. Unfortunately, we are in part of the world where organized screening is not, for colorectal cancer, is not implemented. So many of the lesions that I have been seeing here are quite advanced and not bendable to endoscopic resection, unfortunately. That is something that has been worked on and will definitely get better in the future, but nevertheless, it is something that must be addressed, that since colorectal cancer is becoming the most common malignancy in the world, and given also the other risk factors that we have, the GCC area, such as from sedentary lifestyle to obesity and consanguinity and other things, it is really highly important to actually have some sort of screening for patients to ensure that we do not miss cases that can be treated endoscopically. So right now I'm retracting the scope, and so far I have not seen anything that is out of the ordinary. Everything seems fine. And make sure that I look around all the folds, because it's very important to also identify not just the lesion itself, but also it's the proximal and distal edge of it. I'm already seeing some bloody area here, which I think means that we're kind of approaching the lesion. And right now I have about 40 centimeters in the patient. There's the lesion right there. So it's very important that I make sure that my scope is straight before I try to make any decisions about where this is. And as you can see here, The lesion is at 40 centimeters, and it's around this bend, which means it's around the splenic flexure. There's also another interesting thing. I have been seeing many splenic flexure malignancies, more than actual rectal and sigmoid malignancies. I don't know if this is just a coincidence or there is some biological explanation to this. So as you can see here, the lesion is exophytic. There's around the lesion. There's this right here on the right hand side of the screen. There is this so-called chicken skin mucosa that you can see here. This is kind of a sign that something is actually malignant or like dysplastic going on proximal to it. And as you can see, this is like a cancerous lesion with multiple nodules, where taking biopsies here is quite crucial, because if you take biopsies, for example, from this part of the lesion, let's say, for example, which is this part right here, you can see that the vascular surface is vascular pattern is irregularly regular, so it may show that you have dysplastic lesion that is with high dysplastic number of cells. But if you actually take it right from the center right here, where you see that the vessel pattern and the vascular pattern is totally amorphous, you will definitely find out that you actually have adenocarcinoma. So also, like, taking the biopsies and identifying where they should be taken and how they should be taken is really important. So taking this, we're filming this procedure, so the surgeon will get to see the extension of the lesion, where it starts and where it ends. But if you don't have the possibility to take a video, please ensure that you take a very good image that is from distance, so that it's really clear where it is, and you take that in white light, and then you need to take it in MBI as well. And then you need to take the closer look, so that you give an indication to anybody who's looking at this that this is a high risk lesion. And then you can see specifically right there in the middle where I said there is a 2C component to this lesion. It's very friable, bleeds very easily. So what we'll be doing now is that we'll be taking some biopsies, and then we'll be tattooing the lesion. There's two schools of thought about how to do this. Some people advocate for tattooing and then biopsying, and some people advocate for biopsying and then tattooing. The rationale there is that if you biopsy and then tattoo, maybe there will be some cancerous cells in the channel of the scope that you might end up seeding elsewhere in the peritoneum. So I don't know the scientific evidence behind that really, but logically it seems plausible. So my usual practice is to tattoo and then biopsy. So tattoo, please. And usually when it comes to tattooing a lesion, so usually we try to tattoo about 3 centimeters distally to the lesion, and it is really important to use as little tattoo as possible, because this is a substance that can easily migrate, and it can actually uh, make it quite confusing for the surgeon to see where the lesion is if you inject too much tattoo. Additionally, it is a substance that can be irritating for the peritoneum. So if injected too deeply uh, compared to other dyes that we use in endoscopy. So one thing that we usually try to do is to use the saline uh, method, where we inject a little bit of saline in the mucosa, and only then we inject the glue in that. So as I said before, we retract the scope a little bit, like a few centimeters behind the lesion, and then we put two tattoos on opposite sides of the wall. So we're going to put one bleb of saline here. Maybe loud, please. Inject. Enough. Thank you. Needle in. And then we're going to put another bleb of saline on the opposite side. And can you just hold the scope for me like this, please? Thank you. Hold it like this. Move out. And we always try to inject tangential. Good. Very good, thank you. And now we can take the ink, please. And now there is like about 2.5 ml of is about 2.5 ml of saline in the channel that we need to get rid of. So we need to, before you inject the ink, we need to just put some air or something to get rid of the saline in the channel, and then we'll, so as you can see here, now we got rid of the saline that was in the channel, and now we can put the ink in, and we identify where the blebs are. We have one here and one on the other side, and then we'll be injecting our ink in there. So, needle out, please. Okay, good. And then you just take some saline, and you inject it slowly until you get a little bit of that black. There we go. Look, that's enough. And then we're gonna put more saline in the other one, and the other end, and the other bleb here. Wait. Okay, go. Yes, go. Very nice. That's enough. That's enough. Maybe one. Okay. And now you see that we have we put in you can take it out. Thank you so much. And now we try just to clean the area around the lesion and take a photo that is representative of where the tattoo is, and then we take the biopsies after that. So as you can see here, we have the two blebs that are slightly distal to the lesion, and this will give the surgeon a very good indication as to where the lesion actually is, without damaging the lesion, without putting too much ink under the lesion. This is also very important in cases where we have any kind of polyp or lesion that we're planning to remove endoscopically. That sometimes we ask some colleagues to tattoo the lesion so that we know where it is. Of course, if it's something is in the rectum or is in the cecum, there's no need to do that. But if it's in other parts of the colon, it's important to do that because sometimes some lesions are difficult to find, and some lesions, and sometimes we find like more than one lesion, and we don't know which one the referring doctor meant. So what we try to do here: open, close, open, close. Okay, put some more place. As I was saying, when we ask for a tattoo for a lesion that we're planning to remove endoscopically, we do not want any tattoo that is too close to the lesion, because otherwise it kind of migrates and ends up under the lesion, which can cause fibrosis and makes it really difficult to do therapy. So, and also like the amount of tattoo injected and how it's injected. So these are some of the things that seem to be very straightforward and very easy theoretically, but because there are so many caveats that may actually result in some sort of, let's say, complicating the course of the resection, we try to always pay attention to them. So, open, close, open, close. Okay. Take some more, please. So as I'm taking like these tattoos from the biopsies from the lesion, I can feel that these peripheral parts of the lesion, they are quite soft and they easy to bite. But when I'm trying to take something from the central, the depressed area, I can feel that it's more fibrotic, and there is like this muscle retraction sign, which also indicates that there is some deep submucosal and beyond submucosa is an invasion here of this lesion. So this is a case for colorectal surgeons. I will be informed about this shortly. Open, close, open, close. Take some more, please. And it's natural when we start taking biopsies from these tumorous lesions that they start to bleed easily. They're quite difficult to. It's very difficult to avoid that, or quite almost impossible to avoid that. So, what is more important is if the lesion is lumen obstructing, that we do not force ourselves through it, because that may cause a perforation, right? So natural sequence of events in these cases, if you find something like this during an endoscopy, you should always like communicate with the team in terms of like the steps, what it is that you're going to do, what it is that you want to do, and to have that protocol in place in order to ensure a swift transition from finding the lesion, diagnosing it, biopsying, tattooing. Can you hold the scope is open? Close. Open. Close. From tattooing to biopsying to then organizing the next steps while also keeping the patient at focus as the center of our attention here. Some patients ask you right away what it is that we're looking at, and some patients don't want to know. So it's important also for the endoscopist to have some sort of a rapport with the patient and to try to read the patient, not to say too little or too much. But I personally feel that honesty goes a long way, and patients have the right to know right away what it is that we're doing and what we think that it is. And if you're sure about your optical diagnosis and not in doubt, you can always formulate this somehow in a palatable way, as bad as the news may sound. At the same time, you need to start organizing the next step, which will be finding an MDT for the patient. We'll probably have to undergo some radiology. They will have to meet with the surgeon. Open, close, open, close. How are the pieces looking? Are they big enough or are they good? So like in general, they take about like at least 8 pieces. And we have now what? We have more than 8, right? I think we're happy with what we have right now. I don't see the reason in taking more biopsies. We have taken from the periphery and from the center of it. And I think now we can end the procedure. In terms of planning, further planning, as I said, like, there's a surgeon, there's a radiologist. Sometimes the patient might need a counselor to talk about what we're seeing and what we're doing, and the next steps. Sometimes the family wants to know what's going on. Of course, this is all up to the patient if he wants the family to know or not. Confidentiality is key here. And a lot of patients might ask serious questions about the prognosis and if they will survive this and so on. And these are questions that we do not need to delve into right away in the endoscopy recovery room, but rather keep it for further for later discussion when the patient has had the time to kind of absorb the information that they've just received. And also, if you have a patient that has been heavily sedated during the procedure, do not underestimate the amnesia factor that they get from using benzos and opioids during the procedure. So some patients may forget some of the things you tell them. So that's why it's important not to overwhelm them, things like that right away.